Welcome everyone to today's program. My name is Lindsay Dunn and I'm an editor with Becker's Hospital Review and moderator for today's program. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have allotted, and will follow up on questions they do not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. It is now my pleasure to introduce today's presenters. Asit Gosar is an Objective Health Client Services Executive in McKinsey's Washington, D.C. office, where he joined the firm in 2007. Asit has served healthcare clients across the entire value chain, including provider, payer, and pharmaceutical companies on strategy, regulatory issues, and organization, both in the U.S. and abroad. His recent healthcare provider client experience includes advising on the implications of healthcare reform, improving organizational health, and delivering a meaningful use IT strategy. In his role as an Objective Health Client Services Executive, Asit coordinates delivery of the firm's products and services and works with clients to ensure they capture the full value of their subscription. Before joining McKinsey, Asit held various public service positions. He previously also worked as an intern at the European Commission in Brussels and at the Mayor's office in New Haven, Connecticut. He was also a candidate for alderman in New Haven. Asit has a BA in Ethics, Politics, and Economics from Yale University and a JD from Duke Law School. Our second speaker is Connie Cibrone. Connie is a senior expert in McKinsey's North American healthcare practice and has over 30 years' experience in hospital leadership. In her role as Director of Client Services for Objective Health, Connie leads our assessment team and supports content development for the overall offering. Prior to joining McKinsey, Connie worked in a variety of leadership roles at Allegheny General Hospital in Pittsburgh, Pennsylvania, including 10 years as President and CEO. It is now my pleasure to turn the floor over to Asit to begin today's presentation.
Thanks, Lindsay, and welcome to our webinar. Next slide, please. Okay, so today we're going to be talking about service line strategy. And our presentation is divided into 4 sections. We'll first be talking a bit about context, the overall healthcare environment and how it's evolving, and what impact that has on service line strategy and how we approach it. We'll then move to our specific approach to service line strategy and how we are thinking about those issues. And then I will turn the floor over to Connie, and she will lead you through a case study of how we have worked with the hospital to develop service line strategy and the conclusions that we are arriving at as we look at this topic across the industry. Next slide, please. Okay, so topic of the moment, the Supreme Court. We thought we'd open with a poll to see how you perceive the impact of the Supreme Court's decision making. And so the question we have for you is, what is the expected impact if the Supreme Court strikes down the individual mandate but allows the rest of the ACA to stand? And your answer choices are, out of the 30 million people expected to gain coverage under current law, A, do you believe 8 million fewer people would gain coverage? B, 16 million fewer people?
Hi, this is Lindsay. I think we might have lost Asit there for a second. So go ahead and please complete the poll, and we'll try to get Asit back on the line as these questions come open. All right, and please bear with us, everyone. We are just trying to get Asit back on the line. We do have the poll answers starting to come in, so thank you for sending those to us. Asit, are you there? Let's see. All right, well, it looks like, based on the polls, the most popular was with 34%, you believe 16 million fewer people would do that. I think, Connie, I know you're on the line, but I'm not sure if you are prepared to take over, so we might wait a second here.
I'm happy to try. Lindsay, I'm happy to try, but I'm certainly not going to do it the same justice that Asit would. But I can pick up on the next page if you'd like, and then as soon as Asit gets back, we will turn it back over to him. How's that?
That sounds great.
Okay. So given that question, obviously there's a lot on all of our minds with respect to what's going to happen with reform, and a lot pending out there right now. What this page shows us is the timeline for what's been underway over the last 2 years, and you see by year the plan of what's to happen and what's to occur this year, the readmission penalty, the value-based purchasing, and then some of the premier ACOs. And when you look at 2014, assuming that the law holds as it currently is, we'll be looking at the exchanges and expansion of Medicaid, the individual mandate, big question, the tax subsidies, the hospital-acquired condition penalty, and the employer mandate. So certainly all things that you as providers, so I still think of myself as one every now and then, that you as providers will be facing in the next 2 years. So 2014 obviously is the big year that we're all getting prepared for. So next page. Sorry, I know there's a delay. So the landscape as we are today, we have a lot of things out there. First of all, we know, and it's been all over the news, that we're all waiting on the Supreme Court's decision. It's an election year, and every election year things certainly do change and things get held up, and lots of things that can occur with respect to impacting providers. And we know that the federal government is busy implementing all kinds of things that we just saw and talked about in the prior page. And some states have set up their exchanges, and some are waiting for a result of the Supreme Court decision. But as providers, I think everyone at least that we've talked to out there around the country, our clients are realizing that given reform, and even without reform, I mean, providers are now looking at having to take care of more patients and being paid less per patient. So everybody's starting to feel the impact of that on their bottom line. We're also seeing more integration horizontally among hospitals and vertically between hospitals and payers and with employers and physicians. So I think that our take in 2012 is that providers are going to continue to focus on no regret moves, regardless of what happens with reform, right? In that they want to hold down costs. And really, the topic here today is really one of the things that we'll talk a little bit about, targeting service line growth and opportunity. So we'll spend a great deal of time more on that because, as we know, with less bottom line, providers are going to have less dollars to invest across all different service lines as they have historically. Obviously, there's execution of IT transformation to meaningful use, and then providers are now really looking to developing long-term strategies in which they can thrive. So next page, we have another survey question. And this survey question is around the ideas of focusing on service line growth. And, I think historically providers have tried to do provide services in just about every service line, and given the shrinking bottom lines, they just can no longer afford to do that. So the question that we'd like to pose is, how many service lines do you think that hospitals should prioritize for growth? And by that I mean, if they really had limited capital dollars, where would they focus those dollars? So I think you can vote now. Is that right, Lindsay?
Yes, you can go ahead and vote. We have some, it looks like some polls coming in, some responses coming in.
Oh, great.
And Connie, I don't know if you can see the results, but would you like me to go through
No,
those?
I can't. Yeah, would you mind?
Oh, okay.
I really can't see them. I just still see the questions. I'm sorry. Maybe they were going to be
Sure.
on a computer.
No problem. So for A1, 3% of attendees responded for that. For B, we had 17% of attendees. For C, we had 45% of attendees. And for D, 4%, and for E, 5 or more, we had 16% of our attendees.
Right. So I think, Lindsay, that really does kind of make the point that we just cannot, continue to try to focus on many service lines as you go forward. There's just not going to be the capital to do that, which, if you go to the next page, I think kind of makes the point of why we would focus, right? Why should we focus on service line strategy? So we know that we're going to have less of a bottom line. I'll wait for you to get to the next page, right? We know that reform is coming in one form or another, and it's going to place financial pressures on hospitals. So focus is really going to become essential. You can no longer afford to be, a jack of all trades and provide services from, beginning to end in each service line. We also know that with reform that and just the demographic changes, that utilization is going to change. If more folks have access, then utilization will go up. We have populations that are aging, baby boomers, so within certain specialties there are larger areas of growth and more opportunity that drive certain service lines, which we can talk a little bit about. But hospitals are going to have to look at where they fit with respect to this market growth and how it fits into their mission and their vision, and make some decisions as to which of these they want to actually focus on from their standpoint. And really, success really means that a provider needs to decide where they fit. Again, they can't continue to provide services across the board. So what is their value proposition? Are they going to be the provider? Obviously, everybody's focused on quality, but are they going to try to be the lower cost provider or the higher touch provider? Where exactly will they focus within their overall portfolio and within certain service lines? So we really believe that making these decisions matter, and matter in a big way to the continued and viable success of a hospital. Next page.
And I think Asit might be back on the line.
Oh,
so
great.
Asit, are you there?
I'm here. Do you hear me?
Welcome back.
We can.
Oh, all right. So sorry about that, folks. I'm not exactly sure what happened, but I seem to have lost audio. Okay, good. So now we're going to move on to our approach to service line strategy. Next slide, please. Okay, so leaders must choose a few focus areas from a broad landscape of service lines. When you think about what a hospital does, the range of services it provides is really very large, and so it's a lot to manage. And in an environment where we find more and more hospitals are having their services kind of unbundled over time, and competitors are being able to pick off pieces that they find attractive to stay in. The hard questions are about where to focus and how to prioritize. Next slide, please. Our approach to service line strategy involves having hospitals look at 4 key factors in their decision-making and prioritization. First, we ask them to look at their mission. Mission has a huge amount of influence, obviously, on what services are important to provide, and will be driven by such factors as whether they are a secondary, tertiary, or quaternary hospital, the types of education programs they have, or residency programs they have, the types of research programs they have. All of those, of course, would have a heavy influence on where to focus. We also ask hospitals to look at projected market growth. There's kind of high-level market growth that can be driven simply by population growth, but there's also very, very granular market growth that can be projected, such as market growth by zip code, by sub-service lines, etc. The third factor is margins. Not all service lines are created equal in terms of their profitability, and not all service lines will be equally impacted by healthcare reform. And so margin does vary considerably across service lines and sub-service lines, and we think that's an important factor to be considered as part of service line prioritization. And finally, likelihood of success. Even once you've run the numbers from a growth perspective and from a margin perspective, a lot of other qualitative factors do come into play in thinking about which service lines to prioritize. Next slide, please. Our approach to service line strategy involves bringing facts to the table around two of those four buckets, the market growth and profitability buckets. So I'm first going to talk you through how we do the market growth portion of analysis for our clients, how we've helped them bring facts to that discussion, as well as how we also think about service line profitability. For the market growth portion, we have built a very granular 6-layer model to help hospitals predict demand. It takes into account, as a starting point, demographics, local demographics around population aging and population growth driven by a given county's projections as well as its age mix. We also then layer on payer coverage shifts. There's the secular trend lines in payer coverage that have been going on for a long, long time, such as the slow erosion of employer-sponsored insurance in the United States, as well as the impact of healthcare reform and how that looks at a local level, and in terms of how many folks will get out of the uninsured population and come into the insured population, whether they will be Medicaid or they will be exchange covered, and how many will still stay uninsured. Then we layer on utilization trends. We look at what the trend lines look like at the subservice line level, at the age level across the United States, and how that will impact utilization going forward. We then layer on recent trends around shifts in care from certain types of inpatient setting, certain types of care from inpatient setting to the outpatient setting, as well as the movement from short day admissions to observation stays, and finally the impact of the recession and how that has impacted utilization above and beyond all the trends below, such as the loss of employer-sponsored insurance. So when you put all that together, we also then incorporate one other factor. Next slide, please. Which is, as I was describing, the payer coverage shift. So we have a model that in particular looks at how payer coverage will shift over time as a result of healthcare reform. It takes into account, it breaks the country into about 20 million different cells based on starting with the county, but then also within a county, an age group, coverage, income, race, ethnicity, legal status, employer size, and smoking status. You see that all in the orange box in the top left. So we take each one of those cohorts of people in the United States, and we look at, we try to kind of project for that cohort what are their likely insurance coverage options after healthcare reform. And we look at, given that particular cohort's economic and demographic and medical status, what are they likely to choose as their coverage option? Will they keep their current coverage? Will they move to a different coverage? Will they stay self-pay if they're currently self-pay? And we then run a simulation where we we do a kind of first level simulation where they choose that insurance. That insurance then gets pooled. The folks who have chosen insurance then form new risk pools that then need to be repriced based on who has joined which coverage category. That then leads to a feedback loop where, as a result of that pricing of the insurance, some folks will decide in the next year not to opt for the same coverage, and others will. And so we kind of keep running this simulation until we get to an equilibrium outcome around for each county in the United States as to who has an insurance and which types of insurance they have. So when you put all that together, this particular model around coverage shifts, as well as all the other utilization drivers that we just saw on the last slide, can you please show the next slide? You can see here what is our projection for how service lines will grow over the course of the next decade. So this is a bit of a confusing slide, so let me try to walk you through it. Essentially, what we've done is we've looked at what our model is saying at the county level in terms of these 5 service lines: orthopedics, hematology, oncology, neurosciences, general surgery, and cardiovascular. And for each county, we've ranked we kind of ranked these 5 service lines in terms of how fast they will grow in that county. And then what we did was we then aggregated that information across all the United States U.S. counties, and the result is the heat map on in the middle of the page, where you can see that, for example, in 2,540 U.S. counties out of about roughly 3,000 counties, orthopedics is the fastest growing service line, for example. And in only 2 of the U.S. counties is orthopedics the slowest growing service line. And so the message on the page is, from this work, looking at an aggregate level, is that in most U.S. counties, orthopedics and oncology will be, we predict, will be the fastest growing service line over the course of the next decade. And you can see that the average U.S. growth rate, that's the bubbles on the right-hand side, the average U.S. growth rate for orthopedics is roughly at the rate of 2% per year, versus cardiovascular, for example, we are predicting to be shrinking at the rate of about 0.2% per year over the course of the next decade. Next slide, please. And when we turn now to profitability, the third bucket of the 4 different factors that we use to help develop service line strategy. In the realm of profitability, we've also taken a look now across our database of clients and looked at, looking again at these same 5 service lines, how do we see profitability looking, and how much does it vary across clients? And what we've again seen is there are some generalizable patterns. In general, we have seen that general surgery as a service line is the most profitable service line. And in general, we've seen hematology, oncology being at the lower end of the pack in terms of profitability. And then, for example, orthopedics is kind of more in the middle of the pack. So, while again the results will vary at the local level, there are some general things we do see across the nation. Next slide, please. Now I'll turn it over to Connie to lead us through the case study.
Okay, thank you, Asit. Next slide, please. So taking the things that Asit just described, the 6-layer economic model and the behavior modeling, I want to share with you a client example where we actually applied those models and helped our client make decisions on where and which service lines to focus. So just a little description of the client. It's a 400-bed tertiary hospital with a large Medicare payer mix and a highly competitive market. The number 1 competitor in this market is a large teaching hospital, but the market is pretty saturated with beds. There's 3 or 4 major competitors within that market. Historically, our client has been everything from delivering babies all the way up to end-of-life care and every service line in between. So they really hadn't focused or had to focus in the past on one service line because they had a pretty good margin and were able to invest in just about everything, even if they weren't getting the return. But as with all the things we talked about earlier, taking care of more patients and getting less money per patient, they're going to have, we projected a decrease in their operating margin, so they're going to have less resources, obviously, to invest, so they do need to focus. So next page, please. So using the modeling that Asit just described, and you know, we look very deeply at the market growth stuff as well that he described with respect to looking at our payer mix by service line and our market share by service line and all those things as well. In this page, what we're showing is comparing the projected growth rate by service line to the contribution margin per service line. And this page actually shows what we're projecting with reform. So as Asit talked about the behavior economic model, which actually helps us to predict utilization, applying that with the economic model, we're able to say, okay, what's the hospital service line actually going to look like going forward? So on the x-axis, you have the projected growth rate of a service line, and on the y-axis, you have the contribution margin per case. And for this particular client, and I just want to mention, you know, the national county averages that Asit talked about were averages overall, but we do recognize that each area is a bit unique. So you'll see here, whereas cardiovascular overall was not growing, in this particular market it is. But in this case, behavioral medicine is the one service line where there's actually a negative contribution margin. All the others are positive. But the fastest growing services, consistent with the national averages in this case, are ortho, and you'll see neonatal. And oncology also has a projected positive growth rate. General surgery, though, in this case, a very profitable service line for this client, is actually projecting to have a decrease in volume. And I'll point out the size of these bubbles represent the relative size of that service line for this particular client. So they have a large women's health program, a large medicine program, fairly large CV and ortho program. So with that, if you go to the next page, as we said, those are things that are very important to look at, but in addition, there's some qualitative factors that we want to look at as well for each client. So starting with, okay, given those facts, which services are more profitable and which services are growing, the client had to ask themselves, are there any key offerings or any limitations within the service lines that we really want to focus on? And I probably should have said on the last page that, you know, cardiovascular and ortho are basically something that the client is definitely going to continue to focus on. They are the centerpiece, basically, of this organization. So they're going to continue to invest in those things. But the question before this client is whether or not they invest their resources in oncology or they invest more in general surgery. So they ask themselves a number of qualitative questions, starting first of all with the internal capabilities. So looking at themselves, and they said, all right, are we missing anything in surgery overall? I mean, are there any key offerings that we don't have at this time? And in this case, this hospital really made its reputation around cardiovascular, and they continue to be well known in cardiovascular, and that's had a halo effect for this hospital around surgery in general. So with the exception of bariatrics, they have a pretty strong surgical program. They cover basically every service, from colorectal, ENT, urology. They have all the subspecialties, and they're really well recognized for it. So they know that they need to go out and build a bariatrics program, but at the same time, they really don't have any limitations other than investing in recruiting bariatrics. On the other hand, they looked at oncology, and they recognized that they really have some things missing there. They have a pretty good medical oncology program, but very limited hematology and no radiation oncology. Their radiation oncology was a joint venture with a private group outside of the hospital, and that was dismantled for various reasons. And so they are faced with whether or not they want to invest in going off-site and building their own radiation oncology program. So different issues that they faced in those two service lines. The facility overall had excess capacity from an OR standpoint in beds, so no problem there, but they were landlocked, and they really didn't have a place that they could put a linear accelerator, so they really would have to go off-site to do that. It is I'll mention a CON state where this client is, so in order to do some of the things with respect to investing in new technology, they'd have to get approval, which would also cost them some time. No issues with quality whatsoever. They do a great job, and they're well recognized from a physician standpoint, from a referring physician standpoint, and from the public's perception, particularly on the surgical side. And lastly, I will mention, because of that reputation, there is some loss of cases because folks don't want to wait, and as a result, there's been some, particularly in colorectal, some out-migration of cases going to some of the competitors. So that's really like an overview of their internal capabilities. Next page, please. And looking at the competition, as I said, the #1 competitor is a large teaching hospital, and they have an outstanding reputation across all service lines. And they're really known for cutting-edge technology, being on the forefront of all new protocols, particularly recognized in neurosurgery, which is one of the reasons this client really didn't feel like investing and trying to invest in neurosurgery was the right thing, so their focus was general surgery and oncology. As I said, there are a number of competitors in the market, not just the major competitor, but a number of competitors. And there's no real reason for anybody new to enter because the market's already overbedded and oversaturated. Not a lot of aggressive marketing on the part of the #1 competitor, but on some of the smaller ones, yes, because they're trying to take the market share of they were trying to go after the market share of our clients. So when they look at this situation, they realize that in order to compete, particularly in oncology, where the #1 competitor has a number of gamma knives, IMRT, a whole host of technologies that they would have to invest in, it would take a lot of time and a lot of capital to make that happen. Next page, please. So the last part of the survey that we would look at would be, how does this relate to physicians? And so this is actually in a geography that's really easy to recruit. So it's not been difficult to recruit physicians to this hospital, and they've been able to actually recruit a number of board-certified subspecialists, most recently two vascular surgeons, which continues to enhance their reputation in surgical ability. So the competition recently lost their colorectal group to one of the smaller competitors in the market. The market is moving more to an employed market. It's about 50-50 right now. They haven't really seen any recent shifts in referrals, so they're not really being faced with any competition or any changes in the physician referral base. Next page, please. So what we did was, taking into consideration all the data, the analytics that you saw that Asit shared, and the one page that I kind of shared is just a high-level overview. We used a balanced scorecard to really help the client decide where should they focus. And I said in the beginning, this was really a decision between general surgery and oncology. We looked at 4 major elements. First of all, the vision. This hospital really believes that in order to be successful, they really need to provide the entire service line and all the subspecialties to really thrive. That's their vision. So they do that now, and they do that very well in cardiovascular, again, which their reputation was built on. They don't do that very well in neurosurgery, but when they looked at general surgery, they believe that they're almost there, with a few rare minor exceptions, and really the need to add more capacity from the surgeon's standpoint in certain subspecialties. Whereas in oncology, it would be a bit more difficult. With respect to growth, oncology, while it's growing faster than general surgery, and general surgery's projected growth was actually a decline, they recognized that general surgery margin was so significant that they can't afford not to maintain that market and actually try to make it grow, even if it's taking share from the competition. With respect to the contribution margin per case, as I said, you see general surgeries and orthopedics with the highest of all, which we saw on the prior page. And they really believe that their likelihood to succeed and to do that relatively quickly is better in general surgery than in oncology. So the decision that our client made was to go forward and really try to recruit, add physicians to some of the subspecialties in general surgery to stop the out-migration, to compete with the current competitors, and really to grow their surgical volume. Next page, please. As Asit said, in addition to looking at contribution margin and growth, we do deep dives. It's not as though you're done when you look at those things. You really have to take a service line and dive deeper and look at your market share and your payer and your shift by payer mix, et cetera. So here's just a quick example of the orthopedic service line. And just to orient you to the page, so our client is the orange. It's A. That was our client. And then the other letters are actually are the competition. And so here what you see is for the period of 2008 to 2011, the change in our market share for our client. So if you look at, for example, spinal fusion, the contribution margin per case is pretty significant. And there's been a pretty significant decline in our client, which is the orange, percent of market share. So in this case, we said to ourselves, and they've lost it, to two different competitors. You could see there the letter B and letter D. We asked ourselves why and where, and got deeper into that. And then we also look where we're gaining, but we also look at this information by payer mix as well. So if you look at the next page, please, you'll see we're looking at the commercial market. So just, again, looking at spinal fusion, we actually lost even a greater percent of that market share. So it's just another way of looking at the analytics. So we're looking not just across the service line in general, but we actually dig very deep into each of the sub-services, just to give you an example. So next page, our conclusion. Actually, the next page, please. Thank you. In the summary of key points from what we've discussed is that the reimbursement environment is changing, and we all know that. Even with or without reform, that hospitals really need to make some tough decisions and decide where they're going to invest because margins are shrinking. And hospitals really can no longer afford to be all things to all people. So they're going to have to make decisions as to what they really invest heavily in and what they possibly let go. Focus will bring risk. If you don't focus and you choose not to focus, that could be quite risky, but you're going to need granular data and analysis to really analyze where you should focus. And while these analytics are not 100% sufficient, you also need to understand the qualitative factors like we talked about with respect to the internal capabilities, the competitors' capabilities, and what's going on with the physician landscape. So that concludes the presentation, Lindsay. Turn it back to you.
Yes, thank you, Connie. Thank you, Asit and Connie, for a very informative presentation. We will now begin the Q&A portion of the program. So as a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And our presenters will attempt to answer as many questions as we can during the time. We have allotted for the Q&A, and then they will follow up with questions that they don't have the opportunity to address. So I'll go ahead and kick it off here with one of the first questions that we have, which is it realistic to prioritize at the level of cardiovascular, general surgery, et cetera? Don't all hospitals need to provide services in each of these service lines to some extent?
Yes, I think that most hospitals have to provide some services in those service lines, but it's the extent with which you provide them. So, cardiovascular would include both the medicine and surgical side. A community hospital would have cardiology, for example. They may not have cath, cardiac cath, or interventional procedures. So some, yes, even from a stabilizing standpoint. But when we're really talking about focusing here and investing in developing a much deeper offering in these service lines.
Correct. And I would just add to that, Connie, that there's this. We start out high level in order to get a sense of relative prioritization, in order to get a sense for, like in this case, for the client example that we walked through, that CD and ortho are high priority and should stay very much on their way.
Great, thank you. All right. Let's go ahead and move on to the next question. And I think, Connie, we might have lost Asit again, so I will direct these to you until I can confirm we have him back. Do you think the Affordable Care Act without the individual mandate will be sustainable if that scenario comes to pass after the Supreme Court decides?
The question out there right now is whether or not the entire act is going to be maintained, right? I mean, that's sort of what folks are talking about, whether or not, as a result of the mandate going away, if the entire thing could possibly go away. So, my guess is as good as anybody else's, whether or not we believe that it will be continue to survive. I really don't know that I can opine on whether or not that would happen, but I think there are some very good things in that act, and hopefully some of them will be maintained.
Great, thank you. The next question is, given that hospitals and health systems do not have activity-based costing systems, how can you provide an accurate estimation of profitability by service line or services to guide your client decisions?
Right. So a lot of hospitals, as you point out, do not have cost accounting. And we have actually developed a model where we can estimate the cost of a hospital basically using your cost report data. So it is important to have some estimation of cost, or you really can't do the type of analysis that we're speaking of. So we have a way of doing that for our clients if they don't have their own cost accounting system.
Great, thank you. And we have another question that came through about healthcare reform. How does healthcare reform impact service line growth, or how could it?
That's a good question. I think that healthcare reform is going to, the thinking, right, is that utilization will go up. More folks will have access to healthcare, and that combined with demographic changes, I think certain service lines like orthopedics, where you might have some elective kind of procedures that one might not have had if they didn't have insurance, would now be growing faster. So, for example, I think that might be part of the reason we're even starting to see with the aging population, orthopedics being the fastest growing service. So you combine that with folks having more access to health care through reform, I think there are service lines where you're going to actually see more growth as a result of that, and particularly in elective services.
Great, thank you. And we had another question come through. Do you see states moving towards regional care?
I think in some cases folks are starting to think about that and look at that, but I don't personally think that's going to happen in the next 5 to 10 years. Just my thought on that.
Great. All right, we have a few more questions that I will go ahead and go through. Do you think that hospital mergers fit in with the proposal for hospitals to develop focus, but at the same time are assuming new hospitals with new populations, et cetera?
Sorry, can you repeat that question?
Sure. It's just, do you think that, with all these movement towards consolidation and hospital mergers, how, when they're assuming new populations, how does that fit with this idea of trying to find, a focus?
I think I actually think that hospital mergers help force systems as a result to focus. So particularly when they're in geographies that are relatively close, right? So if you have hospitals coming together within a relatively close geography, it makes it easier to focus, because if you have a service area that could be served for what would have been served by multiple hospitals, you could focus a service line in one particular hospital and use the other hospitals to focus in a different service line, because you're all part of the same system. So I think it actually enhances that focus. It's a tough thing, right? I mean, when hospitals come together as part of a system, they don't generally want to give up any service line to begin with, but I think obviously the margin and the need to create a bottom line forces systems through, once the acquisitions are done, to come to that conclusion over time and to have more of a focus.
Great, thank you. And we have one more question that I'd like to go ahead and ask you from one of our attendees. What do you think will happen in Pittsburgh, an area you're familiar with, between Highmark and UPMC and all kind of the issues going on between the two of them?
Well, that's a good question. I'm hoping that the West Penn Allegheny Highmark deal will be completed, and that the folks in Pittsburgh will have two great options between the two major systems for care. So I again don't have a crystal ball, but as a resident in that area and knowing both systems and having worked in both, that would be my hope.
Okay, great. Thank you. Well, I think we have Asit back on just at the very end here. I think we've gone through the questions that we've had time to go through. If you did have questions, we will follow up with you personally, because we do have a record of those. And a few of you had asked if you'll be getting a copy of the presentation. That will be available on our website within about a week. I want to again thank our presenters for their excellent presentation and for all of you participating today. We look forward to having you join us on future webinars. This concludes today's program. Have a wonderful afternoon.